Today, I'm very excited to be joined by Dr. Shinjini Kundu, who's a resident physician in diagnostic radiology at Johns Hopkins University. She's actually an alum of Stanford University, and she got a BS and MS in electrical engineering here. So we're very excited to have her back. And after Stanford, Dr. Kundu has a PhD that focused on AI and medical imaging. And she is a recipient of the Forbes 30 Under 30 in healthcare, as well as the MIT Technology Review 35 Under 35 for her research. And we're very excited to have her today to speak a little bit on just trying to use artificial intelligence to unravel some of the mysteries of COVID. So Dr. Kundu, please take it away.
Thank you for that introduction. As Dr. Chaudhary mentioned, Stanford is my alma mater. I earned 2 degrees in electrical engineering, ate a lot of comfort food from the academic mom, and it's really good to be back. A lot of great memories. So with that, let me share my screen and we can start with the talk. So today I'm going to be talking about how AI and chest imaging might help unravel some of COVID-19's mysteries. Now, since the lockdowns first started in the United States, it's been about a year, and we're still learning a lot about COVID-19. It remains a part of our lives. We're learning every day about its new symptoms, new effects on the human body, as well as new mutants now. There are definitely a lot of mysteries surrounding COVID-19, and this talk focuses on just a piece of the puzzle, looking at how chest imaging and artificial intelligence could help address some of those questions that we've had longstanding. So we should also acknowledge the tremendous progress and the rapid innovation at multiple levels. So we've had innovation at the molecular level concerning drug development, vaccine development, sequencing. We've had innovation at the medical level, the clinical level, which concerns treating patients with COVID-19, patients who are hospitalized, critically ill, patients who need to be in the ICU and on the ventilator. We've learned a lot about how to treat those patients and how to keep people off the ventilator for as long as possible. We've also learned a lot about treating or addressing COVID-19 at an epidemiological scale. And by that, I mean at a grander scale in terms of preventing spread of infection, contact tracing, double masking, which is now a recommendation by the CDC, as well as things like social distancing. So those are kind of things we've learned at an epidemiological scale. So if anything, COVID-19 has been a use case in rapid innovation at all levels, of which chest imaging and radiology is just a piece of the puzzle. So in today's talk, I'm going to focus on kind of 3 different aspects of chest imaging and AI in COVID-19. In the first part of the talk, I'll go over the use of chest imaging in diagnosing COVID-19 and some of the studies that have pertained to the use of AI in chest imaging and kind of diagnostics. In the second part of this talk, I'm going to propose a few directions in which AI could help expand the role of chest imaging just beyond the diagnostic realm. So these are potential areas where where AI could help with chest imaging in prognostication, in new research, in vaccine and drug development, risk stratification, and things like that. And in the third part of this talk, I'm going to touch a little bit about general lessons learned in rapid innovation and what a post-COVID world might look like in terms of medical imaging as well as innovation in general, some of the things we've learned. So this talk is based on an editorial piece I authored in the journal Radiology Artificial Intelligence. And in terms of disclosures, I have nothing to disclose. So one of the most puzzling aspects of COVID-19 is why some patients are falling so critically ill, while others may be just asymptomatic. So in the early days of the pandemic, in Wuhan, there are two healthcare workers in China, and their pictures are shown on this slide. Um, both healthcare workers, both 29 years old, both contracted COVID-19, both had to be hospitalized. But while one of them recovered and got better eventually, the other one ended up dying. And it's still, as of yet, unclear why some patients do so much worse than others, and why some patients seem to be able to kind of withstand COVID-19 infection. Now, there's certainly a compelling case for chest imaging for COVID-19. Most patients with COVID don't necessarily have pathology on chest imaging, but in a subset of patients, we found reliable evidence of some of the findings with COVID-19. So in the early phase of the infection, you might see rounded ground glass type opacities, and these opacities tend to be located at the sort of edge of the lung, the periphery, and at the lower parts of the lobes. So these are pretty classic for COVID-19 pneumonia in a kind of earlier stage. Now, 4 to 14 days after the infection, there is evolution of these findings. You might see things like crazy paving, which is shown to your left, and signs like the reverse halo sign, which is shown to the right. And these both represent kind of evolution of COVID-19 pneumonia in the lungs. Now, interestingly, crazy paving is not a typical feature of most viral pneumonias. And some of the features that are typical of most viral pneumonias, like tree and bud nodularity, those are not seen in COVID-19 pneumonia. So there is definite evidence of unique features in COVID-19 pneumonia compared to even other types of viral pneumonias, and certainly compared to other types of bacterial pneumonias. So this gives a sort of launching point to study some of these findings in the lung and see what they might be able to tell us about COVID-19. So now I'm going to talk about the use of chest imaging in COVID-19 diagnosis. And this part of the talk is not meant to be a comprehensive survey of the literature. It's just meant to touch on a few key points and kind of highlight a few key concepts and analysis of how chest imaging is currently used in conjunction with AI. This part of the talk is also focused mostly on research and research papers. There are some efforts in industry attempting to develop tools for clinical workflows. To my knowledge, many of those are in proof of concept stages or deployed very locally. There is no tool that has kind of been adopted as a national standard for the workflow. But looking at some of the research studies in this area, it seems like chest radiographs, chest x-rays have been used in deep learning-based triage. So for example, in a study by Wang et al., they developed COVIDNet, which is a open source, deep convolutional neural network, and achieved 83.5% accuracy in classifying different types of normal, bacterial pneumonia, non-COVID pneumonia, and COVID-19 viral pneumonia. There is another study, and there's a tool called CAD4 COVID X-ray, another deep learning system, which was trained on nearly 25,000 chest radiographs and was tested on a retrospective test set in patients suspected of having COVID. So these systems tend to have high specificity, but low sensitivity. So they're good at detecting health or healthy patients, but in terms of the COVID patients, there are still many things that can look similar on the chest x-rays, and certainly look similar to COVID on a chest x-ray. So the vast majority of studies in this area have actually been on chest CT. So the vast majority of research papers have been looking at the chest CT findings and artificial intelligence systems on the chest CT findings. And there have been papers focusing on a three-class classification problem, trying to classify COVID-19 versus other pneumonia versus healthy. There have also been papers focusing on the two-class classification problem, trying to differentiate COVID pneumonia from healthy. And there have even been studies assigning new biomarker scores to the chest CT findings to quantify the volumetric burden of COVID in the lungs. So there are authors who propose the use of a, quote, corona score to quantify this. Now, some limitations of these studies are that, one, most of them are retrospective, and so choosing the patients first and then looking back in time at their images. There have been a few studies, a smaller number, that have been prospective, trying to predict COVID-19 and then comparing to data going forward. But the vast majority are still retrospective. Another potential limitation is that many of these studies only contain tens to hundreds, maybe thousands of patients. And it's not a whole lot of patient numbers compared to the complexity of a lot of these machine learning models. So in order to validate some of these findings, it would be helpful to include more patient data to increase the power relative to the complexity of the models. And another limitation is that the COVID-19 findings are timing dependent, as we saw a few slides back. So it could be that quantifying the change in the images is more important than quantifying what they look like. But that's also something that's potentially open for investigation. But in general, what these studies show is that we do need open source data sets to curate standardized data. Fortunately, there is effort in this area, and we have had some data sets and some databases starting. But these studies also show the need for standard metrics. So in addition to the commonly reported test accuracy, it would be helpful to know the training accuracy, as well as sensitivity, specificity, other sorts of metrics to be able to more fully evaluate the capabilities and limitations of these models. So now moving on to another type of imaging, point of care ultrasound. So point of care ultrasound is very interesting. I think the bottom line that emerges from looking at these studies is that we need more evidence, both for the clinical use of point of care ultrasound for COVID-19 pneumonia, as well as for artificial intelligence systems that analyze point of care ultrasound images. Now, one drawback is that point of care ultrasound requires a skilled operator, so that may limit both the wider adoption of point of care ultrasound for larger numbers of patients. And that also may pose a limitation for comparing results in an AI system, since these are operator dependent, even within the same hospital. That said, I did find some promising studies. So there's a system called PO-COVID-NET, which was able to differentiate different types of pneumonia with high sensitivity and specificity. So these results are promising, but overall, I think we need more evidence for the point of care ultrasound in COVID-19. So given all of these studies, if we go back to the clinical consensus statements, there is certainly compelling evidence of chest imaging for COVID-19 pneumonia, but most of the consensus statements do not recommend chest imaging for the initial screening or initial kind of diagnosis. They do still recommend the molecular test, but there is definitely a role for chest imaging in patients with complications, in patients with cases of diagnostic uncertainty, in patients with critical illness. So this is kind of the niche where the chest imaging falls. And this actually poses an opportunity to study patients who might be sicker and be able to expand the role of chest imaging beyond just the diagnostic realm. So in the next part of this talk, I'm going to propose several potential directions in which AI could help expand chest imaging beyond just diagnosis. And one of these areas is in patient triage. So in times of a pandemic, when large numbers of patients are sick, you can imagine that hospital resource allocation is a real-time challenge. So there have been studies showing that the CT findings may correlate with how sick the patient is and how long the illness will last, as well as recovery. So the chest CT might be an important tool in basically assessing how sick patients are. The chest CT may also be an interesting tool in discovering new risk factors for figuring out who the sicker patients might be. So there's a study by Bai et al., which identified mild patients and was able to predict their risk of deterioration with 79.2% accuracy. And they found that some of the new risk factors for progression are things like age greater than 55 years, hypertension, increased albumin, lymphopenia, progressive consolidation, elevated CRP. And what I thought was very interesting was that they actually found a protective factor, which was fibrosis. So it may or may not necessarily be obvious that fibrosis would be a protective factor, but I thought that was surprising. And certainly the chest images could be used to discover some of these new risk factors in patient demographics and other clinical features that might predict how sick patients are to begin. Closely related to the question of determining how sick patients are is the question of risk stratification, or trying to predict how sick patients might become. So to this end, the corona score might potentially be an avenue, and other scores that quantitatively assess the opacity burden in the lungs, and correlating these with sort of risk of progression, other clinical factors, we might be able to come up with better ways to assess whether patients will become sick. And this might also help with hospital resource allocation, particularly in terms of when large numbers of patients are sick. Another interesting question might be to uncover how coronavirus progresses in different patient populations. For example, how COVID might progress differentially in patients with chronic lung disease versus in patients who are long-term smokers. So it would be interesting to identify how COVID progresses in different subsets of patients to create a more kind of tailored approach for risk stratification. Now, there's a study by Lee et al. Which used the admission chest radiograph to predict whether a patient would require intubation or whether the patient was at risk for dying. These types of studies also kind of might help both in treating the patients and identifying the patients who are most sick, as well as in figuring out what resources may be needed and best matching the resources to the needs. So these are certainly two areas in which chest imaging could be used beyond diagnosis, more for prognostication and assessing risk of patients. Now, we have a few vaccines on the market now, and identifying the optimal vaccine strategy is still kind of an ongoing investigation. So on this slide, we have 7 different vaccine development strategies for COVID-19. We see everything ranging from mRNA vaccine all the way to live attenuated vaccines. And particularly as we know that this virus is mutating, it would definitely be interesting to be able to to know which approach might be the most effective for a long-term protection, and to develop a vaccine that might be able to withstand some of these mutations. So I just want to mention one kind of area, one kind of vaccine strategy, which pertains directly to lung pathology, and that is the spike protein. So the spike protein is a protein on the surface of the coronavirus, and it basically acts like a homing device to identify host cells to infect. Now, quite interestingly, the spike protein binds to cells that are expressing the enzyme angiotensin converting enzyme 2, or ACE2, and cells that express that enzyme are quite abundant in the lungs. So that kind of shows why COVID has a predilection for the lungs, but other cells that express a lot of ACE2 are endothelial cells in the blood vessels, as well as cells in the gut and cells in the lymphatic system. Those are just some other cells. So we see why COVID might have effects on other organs beyond just the lungs, but we can also understand why it might have a predilection for the lungs as well. Now, targeting the spike protein as a vaccine strategy may directly provide a protective mechanism against the detrimental effects of COVID on the lung. But these are still areas under investigation. And I think that in developing a vaccine or in studying the mutations of COVID-19, chest imaging will be a piece of the puzzle along with other clinical data that can indicate how sick a patient is. And it would be very interesting, and certainly AI would help accelerate progress and understanding to correlate to correlate the virus mutation to how sick patients are, and kind of learn more about what makes the virus more dangerous or less dangerous, and maybe down the line use that to develop a vaccine, or to revise on existing vaccines to create a vaccine that actually offers long-term protection. But I think that chest imaging may definitely offer kind of some benefit in that pursuit as well. Now, something that goes kind of hand in hand with vaccine development, or is complementary to vaccine development, is drug development. So we know that COVID-19 affects elicits a strong immune response in a lot of patients. And a lot of patients who do poorly with COVID-19 have cytokine release syndrome. So cytokines are what mediate the delicate balance between damaging lung tissue and actually protecting against the virus. IL-6, a particular type of molecule, may predict respiratory failure. In other studies that kind of precede COVID-19, it's known to kind of correlate with respiratory symptoms in other studies. So it might be interesting to correlate immune markers with trajectory of disease in the lungs and elsewhere. And that may also be an avenue to identifying new kind of immune biomarkers. I think that chest imaging may play a role in that. There are certainly other types of imaging and other clinical data that may also be helpful. And artificial intelligence only offers possibilities in terms of discovering new relationships from large amounts of data that are becoming available. For example, we can develop drugs or select drugs that target new immune markers that come out of such an analysis. Tocilizumab is an IL-6 receptor blocker, which directly acts on the hypothesis of IL-6 mediating lung damage. So this is also another potential way in which chest imaging and AI might help accelerate progress in some of these ongoing sort of studies. Now, chest imaging is only a piece of the puzzle, as we've seen. The promise of artificial intelligence in this particular application really lies in the ability to construct complex models from broad sources of data and identify customized targets. So traditionally, in clinical research and medical research, we've considered traditional sources of data from patients, such as history, vital signs, lab tests, imaging results, to kind of indicate how sick a patient is or how sick a patient may become, or how likely a patient is to respond to treatment. Artificial intelligence offers the potential to be able to include more data that from other scales, as we kind of discussed at the beginning of this talk, from molecular, clinical, as well as epidemiologic scales, um, to, to kind of add data from all of these scales into the model and understand more from a more holistic point of view what complex relationships might emerge. Some other modalities we might consider including are textual processing of scientific literature, geospatial information, things that we may not necessarily have considered in traditional biomedical research or clinical research, but AI may enable us to include information like this. So that kind of brings me to the third part of this talk, which is looking beyond COVID-19. So what are some lessons that we have learned from this pandemic, and what could a post-COVID future look like in terms of radiology, medical imaging, and innovation in these areas? So beyond COVID-19, the first lesson we've learned is that we need to move fast. Now, the scale of the pandemic has shown that we need to perform research quickly, and research that is robust, reliable, and rapid. Now, traditionally, unfortunately, the traditional models of research have been slower. So traditional bench research often focuses on elucidating the mechanisms behind different phenomena, understanding the signaling pathways, understanding the causality of different phenomena. And while this model has definitely stood the test of time and can be thought of as kind of the standard approach in many scientific fields today, it is also very time consuming and may not necessarily be able to yield results at the time scale that we would need in a pandemic that's unfolding in front of us. But data-driven approaches may offer an alternative way to analyze data and understand complex relationships. If rather than trying to understand the causality between two phenomena, so in the previous slide, we have the causality X causes Y, rather than trying to understand the causality, if we are okay with accepting that if we're accepting correlation as an explanation, not necessarily causation, but correlation in the sense that X and Y are related, we don't exactly know the mechanism by which X causes Y, but we can be confident that they are related. And if we can accept that as an explanation, then we can open up ourselves to AI tools, data-driven approaches, which may offer a complementary way to analyze data and understand complex relationships through correlation, and not necessarily the traditional model of trying to understand the mechanistic causal explanations. So I think that, if anything, the pandemic has only kind of shown the potential of AI in answering basic scientific questions. The second lesson that we have learned is data and research standards. So as you can imagine, this is a very fast-moving area. This is an area where new studies are being published every day, and every journal is kind of receiving numerous submissions related to COVID-19, and the literature is moving very quickly. The knowledge is developing on a scale of months, weeks to months. So this has kind of created a proliferation of preprints. Now, preprints are useful in sort of getting the research out there. And research is incremental and helps, these preprints can help inform research down the line. But at the same time, we must keep in mind the caveat that not all these studies have been peer reviewed yet. And we still need a critical appraisal of the quality of the data repositories and research as we're sort of consuming these studies. So this has shown a need for adequate standardization, curation of data repositories, and in a way that honors patient privacy. And this has also shown a need to ensure that the new scientific publications actually adhere to standards and guidelines. So this has also kind of shown the need to, first of all, establish what these standards and guidelines are, and also make sure that scientific progress meets these standards and guidelines. The third lesson that we have learned is moving beyond chest imaging to other types of imaging. As I mentioned, COVID has effects on numerous organs in the body, and we're learning more about its new effects and symptoms every day. For example, we have learned about thrombotic events, strokes, heart attacks, amputations from COVID-19. Some of the ideas in this talk may be applicable to other sort of manifestations and other complications of COVID-19. And those are also potential areas to look into. Now, fourth, one of the kind of exciting aspects is the chance to see the process of in silico to bedside unfold. So we're finally going to have a chance to assess how well experiments in carefully designed in silico environments will generalize to the real world conditions, to the patients that we need to treat, and in terms of both representing the patients that will be seen, as well as guaranteeing the types of results and accuracy that in the real world as we are expecting from the in silico kind of simulations. So this is a chance to kind of see that process unfold. And I think a key aspect of the in silico to bedside process for COVID-19 is the ability to redeploy technology developed for maybe other applications, maybe artificial intelligence systems that have worked well for similar types of data, but now used on COVID-19 data, things like that. I think that those will definitely help accelerate the process of in silico to bedside. But the exciting part is that we're going to have a chance to see this process unfold. So in terms of future directions and things that we're looking into right now, as across the world, we're interested in a long-term strategy for vaccine and drug development. We do have several vaccines available, very exciting news. And it's an open question how well these vaccines will kind of perform as COVID mutates. There's also the question of developing systems for future pandemics. And science is only, excuse me for a second, I need a drink of water. And in this pursuit, science is only part of the equation. We're going to need cooperation from policymakers, from academia, from the private sector, to really work together to try to stop COVID-19. These are uncharted waters, and the precedent we set may persist for a long time. And also, beyond the precedent, the kind of legacy we leave behind may also reach beyond the pandemic. And that may also persist. So in this kind of effort to stop COVID-19, beyond the science, I think we're also going to see kind of unprecedented collaborations develop as well. Thank you for your attention, and I'll take any questions that you have. These are my references, several references. I can provide these if anyone wants to see anything in particular. And thank you.